Okay, hello everybody, and thank you for joining us on this episode of the Akkad and Koka Report. I'm here with my co-host Anish Koka, and I'm Michel Akkad, and we're delighted to have with us Keith Smith, who's the co-founder of the Surgery Center of Oklahoma. And if you haven't heard about Keith Smith, or if you haven't heard about the Surgery Center of Oklahoma, I'm pretty sure that this episode is going to blow your mind. And if you have heard about him, hopefully we'll dig into some, the nitty gritty of how his operation works, and you'll find that very interesting as well. So I'm delighted to have Keith with us. And so I'm going to let Keith, who's an anesthesiologist in Oklahoma, introduce himself and tell us a little bit about the Surgery Center of Oklahoma.
Thank you, Michael, and thank you, Anish, both for having me on your show. I'm an anesthesiologist in private practice in Oklahoma City and have been since 1990. Was recruited to Oklahoma City actually to do primarily cardiac anesthesia, but began to receive an instruction from the federal government about prices as signals early in the 1990s when they cut what they were paying anesthesiologists so severely. What we were paid to do to anesthesia, we were paid for anesthesia for Medicare patients. It was cut so severely that we really had to reevaluate our entire practices and the way we were going to move forward. Thanks to the writings of folks at the Austrian persuasion, I'd come to know that prices were really just signals. And when I was paid $285 for a 6-hour anesthetic for an open heart surgery, and then later that week paid $78 for the anesthesia for a knee replacement, I knew that I needed to respond with a rational signal. I'd been sent a very clear signal, and I sent one back. And so I quit. And I didn't quit seeing Medicare patients. I just treated them all free. I just decided I would not file claims and legitimize that whole process. During all this time, it had become very clear to me that I had been part of the enabling of what I call financial serial killers, which are many hospitals in the bankruptcy of patients in whose care I'd been included. And Dr. Steve Lantier, another anesthesiologist, he and I just decided we could not enable the bankruptcy of the patients we were involved with. So it was necessary to walk away from our practice and own and control our own institution.
So Keith, if I may just clarify here, when you say the bankruptcy of patients, that would be patients who would be either uninsured or underinsured who end up showing up at the hospital and end up with a huge bill that bankrupts them.
Yeah, and actually 78% of medical bankruptcies are people that already have insurance.
Right.
So, yeah, the only way for us to not be part of the problem really was to own our own facility. So we opened the Surgery Center of Oklahoma in 1997, knowing that taking money from the government was a big mistake. And we decided we would never do that. We also decided we'd be honest with patients about what we were going to charge them. And that's really the background and how we got started.
So what happened next?
Well, the first week we were open, we received a call from a young lady who had a breast mass and needed a biopsy, and she asked for a price. And I gulped because I realized I have to answer her question. And, this is why we opened this place in the first place. And I didn't know the answer. So I put her on hold and called the surgeon and asked him how much money he wanted for this breast biopsy. What did he think was fair, mutually beneficial for his professional fee? And of course, he had no idea. And I said, well, come on, you tell me what you're worth. Aren't you tired of, some bureaucrat telling you what you're worth? And so he blurted out $500. And I thought that was pretty cheap, but I took him at his word. As the anesthesiologist, I billed for my time. I knew how long that procedure was going to take, which wasn't very long. And also knew that the supplies, even having been open for 1 week, the supplies that we were going to need in the operating room to perform the surgery really were minimal. So I was about to take her off hold, and I thought again, she asked, how much is this going to be? Well, she wants to know what it is. So I stopped myself from taking her off hold and called a pathologist friend and said, how much do you want for looking at this tissue? And he said, I have no idea. So I said, well, give me a price. And he said, $28. So I added it all up and took her off hold, and the whole thing took about 5 minutes. And I told her $1,900 would be our price. And she said, that's interesting. The so-called not-for-profit hospital down the street just quoted me $19,000. And that was just the facility. So,
right.
And the interesting thing I think about that story is that still our price? You know, that was in 1997. And our price for a breast biopsy is still $1,900, and that's on our website. So the word got around, and the uninsured found us. People with high deductibles found us. People that wanted real quality care found us. All the Division I athletes, the schools started sending those people to us because we really did have just the who's who of, you know, who the surgeons were. The best surgeons worked at our place. And we got very busy. Dr. Lottie and I had both done pediatric fellowships, so we were doing a lot of pediatric anesthesia. And, you know, when you take a child back to their parents remember that after an anesthetic, and then they want you to do their anesthetic. And so we found surgeons were being told they needed to come to our facility, you know, if they wanted to keep, you know, their business. So anyhow, we grew and drew people because of our pricing, and also because of our quality. And it was a booming business. We were still filing insurance claims at the time. And we really outgrew our facility. So we built a new one. And all during this time endured all manner of crony attacks. You know, the venture socialists got together and just really tried to hurt us, put us out. They really did try to put us out of business with various legislative underhanded attacks. And we always were successful fending these off because we took no money from the government. They had no leverage. But I would always tell the legislator, you know, I don't want anything from you. You know, just leave us alone and watch the market work. So we were able to fend off these attacks, built our new facility. And then in 2003, the cronies stumbled on a way to hurt us. They began stacking deductibles on many of the big insurance policies. So patients that were coming to see us out of network, and no insurance company would contract with us, by the way. So all the patients came to see us out of network, and they found that they had to meet their in-network deductible first before insurance paid a dime.
I understand.
That almost killed us.
So let me stop here and just clarify again. So before then, you were out of network. You had no contract with any insurance companies.
Correct.
And the patients will choose to see you. But at the time, it was common for there to be just one deductible. If somebody was insured, they would have one deductible. And if they met the deductible, then after that, they were able to bill the insurance at the out of, the out of network price would kick in.
Yes.
Right. So the patients would get reimbursed a certain portion, the out of network portion. Right. But at that point, after that point, then the insurance companies started having two different deductibles, one in network and one out of network. And the out of network frequently would be astronomical, or both would be astronomical, actually.
Yes, and patients had to meet their in-network deductible before $1. You know, the clock started back at zero when it went out of network. So we found ourselves with our backs against the wall. We knew we were cheaper, and we knew we were better, frankly, than our competitors in this whole region. And I thought, you know, we need to find out what everybody, these self-funded employers, for instance, are paying for gallbladder surgeries, because we know they're being ripped off. We know they're paying more than we charge, or, for tonsillectomy or cruciate ligament reconstruction, whatever it was. And then I thought, well, I can just ask my friends who buy healthcare for their employees out of operational revenue. I could just ask them how much they pay. And then I thought, no, I need to tell them. I need to say, here is what I do and here's how much it is. I need to declare that to them. And that culminated in my decision to tell everyone. Because frankly, initially, our response was to put prices online in order just to save ourselves, because we were in trouble. But the more we thought about it, the more we realized putting prices online would also very likely start a price war, and it would also help us understand why the market was so dysfunctional, why the free market did not work in this industry. Because if you're cheaper and better, your waiting room ought to be full. And it was hurting us to take that approach.
Of course. So you went to the self-funded plans, meaning large companies that don't buy insurance directly, although they may still contract with Blue Cross and so forth to administer, right? That's typically how it works. So Blue Cross would administer, but they bear the insurance risk because they're large enough that they can bear it, and therefore they have a better sense of what things cost, because they directly get the bill on their employees that are going to the hospital.
Yeah, keep in mind that as our business started to fall and fail with this deductible stacking, we had to sharpen our pencils at the Surgery Center of Oklahoma and figure out how we were going to provide for the health and medical needs of our own staff. So with 32 employees, we self-funded. And I thought, well, I'm paying this insurance company $20,000 a month. I know I'm going to spend $250,000 a year on health premiums. Why can't I just buy a policy that covers my staff with a $180,000 deductible and buy, some catastrophic backstop policy behind that? And what I was thinking of is exactly how self-funding works. And you actually don't even have to take that much risk. So with 32 employees, we self-funded. And so I understood how self-funding worked. I understood I wasn't really buying insurance. I was buying medical care for my employees. And that's important too, because if one of my employees had a cardiac event, or they needed some big spine fusion procedure, for instance, I would call, an orthopedic surgeon, or I'd call my friend who runs the Oklahoma Heart Hospital, John Harvey, and say, John, how much are you going to charge me, for this cath and this stent that they put in? And he'd give me a fair price. So I was able actually to create a bit of, we call it a brotherhood. We don't call it a network, but a local sort of brotherhood of people who would actually give a price if you called them. So this whole movement extended far beyond the facility that Dr. Lantier and I run. So I didn't go to my self-funded friends. I just launched the website so that they could see it in the privacy of their own office and see that we were charging $5,865 for gallbladder removal, and the local hospital down the street had just charged their self-funded plan $50,000, and then they could make up their minds whether they wanted to buy cheaper and better.
Of course. And so immediately you see the financial interests aligning as opposed to being at odds.
Yes.
Between the doctors, the plan, the self-funded plans, the patients.
Yes.
Of course. And aligning in a way that is going to keep trying to push prices down.
Yes. And I hated being in an adversarial position with the buyer. That ultimately, I think, is what drove us to open our facility. I realized one day that by accepting money from Medicare, that I truly was seen as a special interest for the care I was delivering someone across town was paid for by my neighbor, who didn't even know that person. So I saw receiving Medicare funds as receiving stolen property and really being a special interest. And so I was in an adversarial position really with the buyer. We didn't like that. So yeah, all of the incentives were aligned. And I think one of the smartest things we did when we came up with our pricing was make sure that the people doing the work received most of what you see as a price on our website. Our facility, the Surgery Center of Oklahoma, almost runs like a not-for-profit. We have the profit margin of our facility whittled down very aggressively. But what a surgeon receives, for instance, for a cruciate ligament repair or anything else you see on our website is much, much more than they would receive from any of the insurance carriers they work with.
That's remarkable.
It's really a remarkable story there. So and it's remarkable to read about, and it's still remarkable when you say it. So why do you think this isn't popping up elsewhere? I mean, why does it take a courageous group of folks, in Oklahoma to do this? And what do you see the barriers as this happening all over the map?
Well, it is happening all over the country, and I would encourage any of the physicians or listeners to keep their eye on the Free Market Medical Association. That's the organization that really renders the accuracy pulse of how this movement is growing all over the country. I would argue that the direct primary care movement is really a parallel but very similar, take back my life and practice and deal directly with my patients kind of movement. There are facilities like mine that are popping up all over the country. Some are very much like our business model. Some are hybrids. I don't think necessarily that our model makes perfect sense in some other region of the country, but it might. So yeah, it is popping up all over the place. I think one of the reasons that it started in Oklahoma is that there were not terribly restrictive certificate of need laws here, and that we actually were legislatively successful in battling the goons at the state capitol and their crony pals at the hospitals. But the reason primarily that we were successful legislatively is we didn't take any of their loot. We didn't take any of their money, so they had no leverage. And without any leverage, they just couldn't reach back in their toolbox and find a hammer that they could hit us with. And so they typically left us alone. And frankly, I've got to give the Democrats in Oklahoma the credit because they saw us as the underdog. It was the Republicans back in the early days who were waving the crony flag of the big hospital systems and were trying to put us out of business. The Democrats, not to a man, but they largely saw us as an underdog, and they saw us as a champion of the poor and the uninsured.
So let me, it's very interesting. You talk about the certificate of needs, which those are legislations that were adopted by many states. In fact, at some point, most states had some CON legislation, which means that the state had to approve any healthcare facility before it could be built or operate. Is that right?
Yes, it was actually started by the federal government, but then they allowed the states to opt out of it. And I think all but about 37 states did opt out of it. But yeah, there's the majority of states have restrictive certificate of need on various parts of the medical industry, whether it's surgery centers, hospitals, imaging, nursing homes. And of course, it's most appropriate to visualize the committee that you have to make your case to enter the marketplace as a star chamber, because it really is made up of the people who don't want you in the marketplace. So the
course.
existing members on the board, that are going to, decide whether you get to open your surgery center are typically the surgery center administrators that don't want you in the marketplace.
So that
right, that was my part of my point that I was trying to lead towards in terms of why this necessarily isn't popping up, all over the place. I'm in Philadelphia, which is a very, very, very high cost area, and there are these large, massive healthcare systems that have multiple facilities set up, and I hear my colleagues, my surgery colleagues, complaining all the time in terms of what the reimbursement is for them versus reimbursement for the facility. There's a massive differential. There's a report out recently that looked at the differential for neurosurgery procedures in terms of the ratio between hospital and reimbursement versus surgeon reimbursement, technical versus professional. And it's grown from the 1980s to now. It's like 20 times that. The ratio is 20 times what they get paid. And it always comes back. And why is it that there aren't a band of surgeons? If this was organic, there'd be a band of surgeons that would say, forget this, and they would set up shop just like you've been able to organize, set up shop right next to these massive behemoths and essentially disrupt them. But the certificate of need laws was a huge block against doing that. And the hilarious thing to me is that the certificate of need laws are used as, if anyone says anyone's certificate of need laws, people throw up that we need this to help control costs. It is doing the exact opposite, and people can't see it. And so hearing you talk about, it'd be very interesting to hear you talk about other regulatory barriers that you've said you've obviously part of the reason you've been successful is because you have been able to fight against some of this cronyism, and cronyism is bipartisan. Depending on who's in power. So I'm fairly sure in Philadelphia, which is blue as blue can be, the status quo is sending a large number of dollars to whoever's in power. So in your case, it's the Republicans. In this case, it'll be the Democrats. And as soon as you come out with something against that, these folks will cry something or the other that it's you're doing it to protect the patients and whatnot, and it's doing the exact opposite. But it'd be very interesting to hear about other things. So certificate of need laws is one thing. Are there other regulatory things that you successfully fought off in terms of things that'll other big barriers to doing what you've done?
Yes, and before I get into that, you should know there's a very active state chapter of the Free Market Medical Association there in Pennsylvania. And so there are a group of surgeons and direct primary care doctors that are coming together and deciding they're going to take back control to the extent that they can. And the information you said at 20-1 for institution to surgeon payment, that's new to me. That is very powerful information. Those are the kinds of pieces of information that more and more people should know. It's devastating for a hospital to claim this, not-for-profit status when they're just building empires and making out like bandits. That we also battled our state health department for quite some time. Oklahoma, in the past, was not different from a lot of states where the cronies used the state health department as a hammer in their toolbox. We actually had to sue our state health department back in about 2002. They notified us that they wanted all of the medical records for all of the patients we had operated on in the year 2000. And I told them no. And they said, you don't get to say no. And I said, well, I'm saying no. None of these patients, gave their consent to give you this data. And they said, well, we're the state health department. We don't need their consent. And I said, well, then you can't have them. And they said, well, then you're going to be closed. And I said, that's fine. We'll see you in court. So we filed an injunction to stop them. And in the discovery process, realized they didn't even have the statutory authority to collect these records. But in the meantime, they had collected them from every other surgery center in the state that just, said, yes, come get them. Of course, we don't have electronic medical records, and so that means they would have to rent several rider trucks to come get ours anyway. But yeah, we fought the health department. We're actually on good terms with the health department now because all of our infection rates are online, and the employees of the health department know where they want to go if they want to have surgery. So we're actually on very good terms with them now. Although the state health department in Oklahoma now is embroiled in a scandal where they had a slush fund with untold tens of millions of dollars that they did not disclose to the legislature. So they're on their heels. They have some other things to worry about than carrying out the vicious desires of the big hospitals.
So Keith, go ahead, Anish.
Sorry, Michelle. I have to highlight something that Dr. Smith said right there. You're doing all this without an electronic medical record, is that correct?
Oh, yes, absolutely. Yeah, we don't have any plans to have electronic records.
Right. You're telling me that it's possible to deliver good care to somebody without an electronic medical record? This is unbelievable in 2018, Dr. Smith. What kind of heresy is this?
I don't know how you deliver good care with them. We don't have any plans. You never say never, but I don't have any plans to buy a system like that.
So I'd like to take the opportunity here to see how many myth that we're hearing from the health policy geniuses you've debunked with your experience. First of all, it seems that maybe a year or two ago, they suddenly woke up to the importance of price transparency. And now you hear, in JAMA and other journals like that, papers being written by the health policy gurus about how important it is to have price transparency, and so important that it needs to be mandated. Now you've had your prices transparently on your website for 15 years or more.
10 years.
10 years. Did the health policy gurus consult you? Did they come to you and say this is a great idea?
I would turn them away. I don't think I'd even meet with them. It would start some rumor, that I
right. So they want price transparency to be mandated now. They want it to be mandated. What is it they're not getting about mandating price transparency?
Yeah, and Colorado, the state of Colorado has a bill right now that's going to mandate transparency, and most people don't know that inside of the Unaffordable Care Act there was a requirement for hospitals to post prices, but of course they've all ignored it, and thank God, because mandating the free market or mandating price transparency is a real mistake, and I've been called out because I don't want it mandated. Somebody the other day accused me of not wanting it mandated because I didn't want competitors, and that if they all were forced to post their prices, then I would suddenly have all these competitors. But the reason mandating price transparency is a bad idea is that it can only happen and it'd be the result of inviting the most corrupt organization and regime that mankind has ever invented, called the state, to the party. The first thing that would happen is that legislators, after they mandated price transparency, would sell indulgences. They would allow certain facilities for a price to not post the prices. And that would be very lucrative for the statesmen, so-called statesmen. The other thing that would happen is, just like on the front page of any sort of legislation, there would be a definition of terms. And price transparency would be redefined, in all likelihood, I argue, to suit the price gougers it's meant to regulate. And so every opportunity the legislators have to shake down the industry or to sell favors or to extort enemies, every opportunity they have to monetize their extortion, they'll take advantage of that. So involving the most coercive and corrupt invention of mankind in the free market is not a good idea.
I think you're absolutely right. And the in the free market, price transparency is a necessary consequence of a free market approach. I mean, you don't go to a restaurant that doesn't post their prices. If you're going to survive on the free market, you have to post your prices. I mean, that's clear.
Right.
So what happens here, the reason prices are not transparent in the regular healthcare system is because there's this antagonism between the insurance, the patients, the providers, and so forth. But in fact, the prices are actually quite transparent to the people to whom it matters. The government, Medicare, knows exactly how much they're going to get from you, or from a doctor who's on Medicare, and so do the insurance company, because essentially they are setting the prices and they know what the prices are. The fact that the patients don't know about them is almost irrelevant, because the financial transaction doesn't involve the patient, except for the copay. So they completely miss the point about why there isn't price transparency. And if they miss the point about why there isn't price transparency, mandating it is not going to fix anything. And as you said, it's going to only create more opportunities for obfuscations and redefinitions of things and layers of bureaucracy.
And I would take it even further. You're like one of the nicest people I've ever known, and so it doesn't surprise me you're being magnanimous by saying that they missed it. They don't understand. I think they do understand. I think they're diabolical, and I think they know exactly what they're doing. To grant them ignorance is a very kind gift, and one that I think is undeserved. Keep in mind too that one of the, and I would say the greatest price obfuscator is the federal government. Physicians who work for hospitals are paid multiples for the same procedures and the same diagnosis and procedure codes that doctors who don't work for hospitals.
That's right.
So, let's make that transparent so that everybody knows, how their tax dollars are being squandered.
And so that brings another point that I wanted to talk about, is that as we discussed so far, the prices in hospitals are astronomical compared to the way they are either in doctors' offices or in ambulatory surgical centers. But I'm seeing more and more, and I wonder if you don't have anything to do with it, because it may be in reaction to what you're doing. I see more and more reports, again, coming from the geniuses that run the health policy centers and whatnot, against ambulatory surgical centers, claiming that they're unsafe, there's poor quality, there's poor oversight, and so forth.
Right.
And I see this more frequently, and I don't know if it's not precisely because they are feeling threatened. They are trying to defend the status quo, trying to defend the hospital establishment, and so they're making claims that are completely unbacked, that have there's no control. They cite anecdotes of complications occurring in an ambulatory surgery center, and so forth. Now, let me ask you this: it's a softball. Do you have an interest in being careless about quality and infection rates and things? I mean, is that going to be in your interest to not pay attention to quality? And do you need to learn anything from the bureaucrats in the health department telling you what it means to run, a clean, high quality surgical center?
Well, of course, we are not on any insurance plans. Blue Cross, United, Cigna, Aetna, Humana, they pay multiples of what my web prices are across town at the so-called not-for-profit hospitals. And they want nothing to do with me, in spite of the infection rates and complication rates that we have listed on our website. We don't have patients in our waiting room, therefore, because we're signed up with a bunch of plans. If we're not really good at what we do, if we don't really provide a service that the market frankly does and should judge very harshly, if we don't provide a service that people want to buy, then we're out of business. So we've actually put our money where our mouth is, and if we're not good, we're gone. We're like, we put ourselves in the same position as a restaurant. if they serve poisonous food or have horrible service, they're going to go out of business. The market's going to be very harsh. But you and I both know there are hospitals and physicians and facilities that are signed up for any number of insurance plans whose waiting rooms are full, when really there's very likely butchers amongst them or just horrible care.
Absolutely.
Yeah.
So Keith, tell us a little bit about the operation now. It's been 10 years since you've been posting your prices online. What does it look like? How how many procedures? What do you do? What's the range of things that you do? And just give us a little flavor of the operation and the scope of it.
Yeah, we until December of 17, we were averaging between 600 and 700 cases a month. So about 8,000 cases a year that ranged from all manner of pediatric sort of surgeries to orthopedics, ear, nose, and throat, urology, gynecology, general surgery, oral maxillofacial surgery, spine. So it's ophthalmology. It's a huge gamut. But as I pointed out earlier, anybody that we deal with has access not only to the pricing at my facility, but the pricing at all the facilities in the entire United States that they're willing to come talk to us or email us. I referred, I think, two patients to Virginia last week because Dr. Bill Grant has Monticello Surgery Center out there. And these people were from North Carolina and they were going to come here. And I said, why would you come here? Go to Virginia, have your procedure there. He's got a website that is exactly like mine because I gave it to him. I said, here are my web designers, copy us. By the way, Bill Grant is someone you might have on your show. He's an expert on certificate of need because he actually fought that successfully in Charlottesville, Virginia.
Okay.
So,
Dr. Smith.
Yeah, go ahead.
Sorry.
Well,
one of the things that, in terms of how it is you do it, part of the secret sauce for your prices being low, is it not the case that it helps, of course, that you don't have to staff an ER 24/7. You don't have to. You can cherry pick in some senses the patients, or the patients who come to you are kind of self-selected, meaning. You're probably, the case mix is probably not as sick as perhaps some, as most hospitals per se. So how do you, how would you respond to critics that would say that, this is great that the Surgery Center of Oklahoma does this, but, they don't have to deal with uninsured patient population or a much higher risk patient population than what hospitals do?
Yeah, most of the patients we deal with are uninsured, and many of them come see us because the price gouging hospitals have run them our way. I'd also say this: I challenge people when they drive across town, when they drive across the state, look for the largest building in any given town or the largest complex in any given town, and it's very likely the hospital. And I would also challenge them to look for the emergency room and find the emergency room because that is the area most likely to have a building crane out in front. So the whole notion that, we have an emergency room and, because of that, we have to bankrupt everybody else that comes through the doors, that, common sense just, it doesn't equate. Why would you build on to your loss leader? And I'd go further. There are hospital systems here in Oklahoma and even outside of Oklahoma that are building freestanding emergency rooms everywhere. They're metastasizing this loss leader voluntarily all over the place. And it just doesn't make sense to me if that were their loss leader, that is what they would do. Also keep in mind that hospitals are making so much money most of the time, particularly the big systems, that they need all the red ink that they can find to justify the fiction of their not-for-profit status. So, a hospital bills $100 for an aspirin and receives $5 for the aspirin. they'll poor mouth it and claim they lost $95 when you and I both know they paid probably a penny for the aspirin. And so this is part of the real poor mouthing propaganda that the American people have been exposed to. And now the whole argument about cost shifting, having to bankrupt, people who come in so that they can somehow just get by, by taking care of all the uninsured folks or people who don't pay them. It's simply false. Somehow they have all the money to build on and buy physician practices. Hire more and more administrators. My facility doesn't even have an administrator. You're looking at him.
Let's talk about another myth that we hear a lot. So every medical student, every resident, every fellow, and every doctor in the country is hearing again from the health policy geniuses that if you operate on a fee-for-service basis, you do a lot of unnecessary surgeries. How many unnecessary surgeries do you do at your facility? Do you have a breakdown on the number of unnecessary surgeries?
Yeah, well, 0. And that's a great question. What our arrangement is this: if the Surgery Center of Oklahoma were known as a place that did unnecessary surgery, the Surgery Center of Oklahoma would not exist, because people would not come there. Again, I mean, our reputation is everything. Even to dig deeper, our relationship with the self-funded employers, basically at the end of the year, they look at their experience and, did we spend more or less, in our health plan, or did we spend more or less on surgery than we did, the year before? And the accountability is built in for, the surgeons to really be appropriate, not overly conservative, but to be appropriate and provide the appropriate care. I shudder to think about what some of my surgeon partners would do if they found out one of their colleagues had done some unnecessary surgery. He probably wouldn't survive it, because that's our business model. It's if we suspected that was going on, we would first eject that surgeon from our facility. He would not operate there because it would place all of our reputations and our business in jeopardy.
One more question along those lines. First of all, again, the geniuses tell us that in the fee-for-service, in the private practice world, there's a fee for everything, and whereas it's much more cost-effective to bundle prices. Well, you're bundling prices, right?
Yes.
You're having one price for everything, which
Yes.
goes to show that that theory really doesn't hold water. Now, if something happens, I mean, you guarantee your price, but if something happens, for example, there's a need for a repeat surgery or a complication, how do you deal with that, sort of on the practical level?
Yeah, we deal with that on a case-by-case basis. When we first launched our prices, we thought about padding them, but with some certain percentage so that we could just provide a blanket guarantee. And then we realized when we really started looking at our numbers that complications were so rare that it didn't make sense to charge everyone who came along as if they might have a complication. One of the most interesting ideas I think that the market has generated is the idea of plane crash insurance that patients can buy prior to a medical procedure. And I think the market is going to provide something like that. What we do is our model of delivery is the exact opposite of what the prevailing model is. Most facilities and physicians, apologies to your current audience, they're geared towards maximizing revenue. I don't know how many emails you get, but I still get email after email, attend this seminar course on coding and how you maximize revenue. We've stood that on its head, I think, and we are focused on delivering maximal value. And so that is the overarching philosophy that we use when we approach any care particularly if someone suffers a complication. So we had a diabetic smoker who had bunion surgery, and she developed a complication. She had an infection, but she was at risk. And so I called her employer, who's self-funded, and I said, listen, this is unfortunate. It's not much of a surprise, really, but it's unfortunate. But the surgeon and I are going to donate our physician services. And what I'd like for you to consider is just to cover this cost of the supplies at the surgery center, the total for which for these next 3 surgeries, I think will be right about $900. And the employer said, you need to have more complications. And I said, what? He said, if your goal is to demonstrate outrageous value, there's no way you could have done it better than the conversation we just had. So if your thought is, I want to render maximal value, not extract maximal revenue, then treating people gently through something as disruptive as a complication, it goes the way it naturally should go, where the experience continues to feel mutually beneficial.
Anish, do you have any other question?
Yeah,
I have a couple more, but I want to give you a chance.
Yeah. No, absolutely. So is would you favor something? I mean, there are of course folks that are truly destitute and need charity. Aren't able. How do we as a nation? What would be your plan to dealing with folks that truly don't have any or income in order to pay for this? Is it all charity? Would you favor some type of third party federally run thing which provides some type of safety net, or I'm curious to hear what your thoughts on how to deal with those folks.
Yeah, I think the poor are individuals, and they deserve better than to be treated as members of a herd. When you look at what the state has come up with and what government has come up with their ideas about how to take care of the poor, I think the results are abysmal. I think charity is the way it should be done. It should be done locally as well. I encourage any of the listeners to familiarize themselves with a writer, Leopold Kohr. It's Kohr, who's famous for saying, wherever something is wrong, something is too big. And so this yearning for a national solution or a state solution, I think is misguided. I think that when a destitute or poor person comes in, that they be dealt with as an individual. And then again, as my buddy Steve Lantier says, at the current pricing, we're all poor. So, what is poor? Is poor mean that someone cannot buy the $118 necessary to pay for the supplies for a tonsillectomy for their child at our facility? Is it someone who has absolutely nothing? Their GoFundMe options. Whenever someone in a real naysayer role asks me, what about the poor? I said, well, what poor person do you have in mind? Oh, the poor in general. Oh, I said, you mean the poor in aggregate? Well, if you're going to consider the poor in the aggregate, then offsetting that on the ledger sheet, you must consider the aggregate benefits that the market provides. Think of all the money that is not spent by patients at our facility on care that had they received it across town. And that would enable all of those folks to be more charitable with their neighbor and fellow man. So I don't think you can consider the poor in the aggregate and without considering the benefits of the market in the aggregate, but you darn sure do the poor no favor considering them in the aggregate, because the inclination that no state has ever resisted comes along, and it's to deny them care.
That's very well put, Keith. That's really terrific. Absolutely right. I have a question about your docs and whether are they have practices outside of the Surgery Center of Oklahoma, presumably. and they're not opted out necessarily of the system, in terms of their other practices. Is that correct?
Yes, we have 105 surgeons on our staff now. Not all of them have opted out. Some of them have. There's a significant number of my ear, nose, and throat partners, for instance, that have opted out of Medicare. They practice at multiple facilities, including mine, or theirs, ours. But it's definitely their favorite place to work by far. They would all say that.
And so it's the model, the private practice model so far seems to lend itself very well. I mean, the free market model seems to lend itself well in the current circumstances, where you have to compete with the behemoth of the hospital insurance government system, if you will. It lends itself well to primary care physicians and to surgical specialists that offer, sort of punctual treatments for people in need. Is there a way that you see this being expanded to other parts of the, the medical profession beyond the primary care and the surgical specialists?
Yes, I think, as I told a group in Dallas this past weekend, it's coming. I mean, I talk about this idea. It's a horse that's out of the barn. It's not going to come back. The idea that you can do this cheaper and better, it's out there. And what many physicians, I think, are going to face if they are not prepared and haven't thought through joining this movement is being steamrolled by it. Just an idea of the size of the buyer base. Now, the government doesn't care what anything costs, and they're about half of the medical services purchased in the United States. Of the other 50%, 80% are self-funded buyers. These are people who, like me, now with 43 employees, I have the sticker shock. If I'm charged $100,000 for one of my employees for their pacemaker, and our price online is $11,400, which includes the device, then that matters to me. That $90,000 comes out of our bottom line. So 80% of the buyers in the United States that buy healthcare that are not related to the government, they have sticker shock, and they all know that better and cheaper is a possibility, and that it's actually being practiced. And so for the physician or the hospital or the institution or the imaging facility or the pathology group, for them to not acknowledge this and begin to wrap their minds around implementing it themselves, they probably will be left behind. And they don't have to be adversarial with their buyers. Everybody at my place has got a smile on their face, and the people who buy from us have a smile on their face. And it's also nothing new. This was the way people practiced, before Medicare and Medicaid took over and, began destroying the market. So I would encourage people for their own self-interest, really, to investigate these ideas and keep your eye on it, because when it happens, it will happen in a revolutionary, very quick way. It's happening very slowly. But when I see Josh Umber and Lee Gross and Ryan Neuhoffel in the Rose Garden talking about direct primary care as part of the solution, it's coming.
The problem I see, Dr. in terms of the time frame and how quickly this can happen is that you have these massive too big to fail health systems that employ and are funding this healthcare bubble. I mean, you look at Philadelphia in terms of how there's been this resurgence in the city, and there's this massive growth, and real estate prices are up, and you really see the engine of that as being this debt financed healthcare bubble that's driving it. Same thing in Pittsburgh, the largest, steel, as you're saying, the steel building used to be the tallest building. Now as you drive in, it's UPMC. Yeah. And again, there's a massive growth in the city. I mean, the city is beautiful. There's these beautiful, places that were run down are now beautiful again. And it's just remarkable to see how the city has changed. But that's because of these kind of fake healthcare dollars, these debt finance healthcare dollars. And so anyone that tries to take on these large vested interests that now employ such a massive number of people in these cities is going to run into massive regulatory roadblocks. I think I don't know how I don't know how that's going to happen. One is the certificate of need law, certainly, but there's many other ways that the health systems are working to try to keep themselves where they are. So I think I really wonder how we can actually go about doing this without things actually failing.
Well, there are always dislocations when the market is at work, as there should be. I mean, the horse and buggy folks, I'm sure, were very upset with Henry Ford. There are always going to be dislocations, and it's the job of the entrepreneur and the forward thinker to anticipate the needs of the consumer, not to crawl to the city council and beg for permission to hamstring the competitors. So I think it happens one physician, one facility at a time. But once it happens, the existing price gougers will mend their ways. Take a look at UCLA's website. They copied my website. They actually have cash pricing on their website.
I was going to ask you, actually, that was my last question, is that I think you've had an impact, or you're having an impact, even if you're in a different state. People must know about you, and they can't, just your mere existence on the map, so to speak, must prevent the price gougers from gouging as much as they have been so far. Would you agree with that, or do you have a sense of that? That just the mere fact that you in Oklahoma City have been posting prices, that they can't continue to play the same game?
That's correct. There was a fellow in Georgia that was quoted $40,000 for a urologic procedure we have listed on our website for $3,600, and he told the urologist he was coming to Oklahoma City, and the urologist said, "Well, not before we go talk to the administrator." And they waived my pricing out in front of the administrator, and he said, "Well, we'll do it for $4,000. So the patient called me and he said, "You realize you saved me $36,000 and you didn't even perform the surgery." So this price war is going on. I mean, there's a hospital in Philadelphia that's copied our website. I don't remember the name of it. There's an outfit, and UCLA has copied our website.
Let me actually show, because I can do a screen share here. I just want to show the audience quickly. The people who listen to this on webcast, when we go to webcast, may not see it, but it's just, I want to link to your website here, and how simple it is. That just on this is the homepage, and you have the different body parts here, and you just click on, here it's the shoulder, and then you can select the kind of shoulder procedures that one would want. So open rotator cuff repair, you click on that, and there you have your quote right there, completely bundled, guaranteed. It's just absolutely amazing.
Michelle, you're gonna make the health policy gurus mandate this in their next.
Let them mandate as much as they want. As Keith said, I think the free market is unstoppable. It really is. So I understand your point, Anish, but I agree with Keith. I think it's unstoppable. And the sad thing is that go ahead.
Sorry. I think it's going to take us for some reason as a physician group, and you can talk about who it is goes into, how it is we're selected to be physicians or whatnot. But, and I made this point multiple times elsewhere, that for physicians, it's remarkable to me. You'll have a group of these super smart physicians that have always been at the top of whatever class they're in, and you'll have someone sitting up there in the front of their class, in the front of the room saying, there's some crazy thing, and the response from the physicians is, all right, well, that's fine. How high do you want us to jump? There's no, we need as a group of physicians to be less like lemmings and more like Dr. Smith to get anywhere. But as long as we just keep going along with all this, I think progress is going to be slow. And I think we need folks to, unfortunately, show us the way. And I think Dr. Smith, is really done that. Hopefully, we can instill some courage.
Right, but doctors should be nervous. I mean, I think that's the point that Keith was making, that doctors should be very nervous because they're going to get steamrolled, or whenever the whole behemoth comes crashing down, they're going to get hurt too. So they need to think about plan B ahead of time. And ahead of time is right now. Right now they need to think about plan B. And so, I think we need to wrap things up here. And Keith, I'd like you to give us the websites of the two websites, one for your surgery center. The other one is for the Free Market Medical Association, because, doctors are indoctrinated into socialist healthcare, and they really need to learn what the free market, not just from your example, but also a little bit about the theory of how it works, how they can counter the arguments that they hear from the health policy geniuses. And so I want to direct them, and we'll put those on the show notes when our website is up. So what are the websites?
Yeah, well, the website of our facility is surgerycenterok.com, where all of our prices are. There's also a link to a blog and some media interviews that I've had, some of which are frankly comical. And the website for the Free Market Medical Association is FMMA, freemarketmedicalassociation.org. And that's a gathering of buyers and sellers. And part of our purpose is to teach physicians, the market principles that every other industry in the country has to endure. I don't judge physicians for being socialistic and very fearful because we were primarily taught by socialists in a socialized system in our medical training. But it's Anish is right. I mean, very smart people in the room, but people who are very fearful. And I would argue, I think I could make a compelling case that the fear that physicians have has been very well orchestrated by those who would leverage them. And if somebody does feel afraid, if they feel like, I don't want to get involved in this free market movement because I'm afraid, then I would encourage them to acknowledge their fears and figure out, where is the leverage coming from? How do I minimize leverage, whether it's debt, whether it's a mortgage, whether it's, whatever it is? How do I minimize my leverage so that I can act as courageously as possible, because I owe it to myself, and we all know our patients deserve it.
That's absolutely a great way to end this. We've abused of your generosity, Keith. Any final brief question, Anish, or should we wrap things up here?
It was fantastic talking to you and hearing from you about how you've done this, and great. This is great, and I loved your points on how it is we deal with folks with folks that can't afford it. And your point should really is well made in terms of what does it mean to be poor, and how we can expand access to as many folks as possible with a model that's very different from what we're talking about right now. So great points. Thanks so much for giving us some time.
Thank you. My pleasure.
All right. Bye-bye now.